Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode 19. My name is Scott Okuno, a medical oncologist at Mayo Clinic and Chief Medical Officer of SARC. At SARC Talk, we interview interesting people who are connected to sarcoma, where we can share and spread the knowledge about sarcoma. I'm pleased to have Dr. Angela Hong, radiation oncologist and professor of clinical medicine at the Sydney Medical School at the University of Sydney. Dr. Hong received her undergraduate medical degree at the University of Sydney. She spent some time doing research at Memorial Sloan Kettering Cancer Center in New York. She also went to University of California, Davis, and did research there. She also then came back and completed her radiation oncology residency at the Royal Prince Albert Hospital in Australia, and went on to get her Master's of Medicine and PhD at the University of Sydney. Dr. Hong is an active member of several societies across Australia. She's an active SARC investigator of our recently completed Stand Up to Cancer SARC 32 study, where we did a randomized trial of neoadjuvant radiation therapy and surgery with or without pembrolizumab for soft tissue sarcoma. Please welcome Dr. Hong.
Good morning.
Dr. Hong, thanks for getting up early in Sydney time, so we're appreciative of this. So it's good to see you. And the last time you and I saw each other, it's hard to remember, that was back in CTOS in Dublin at the investigator meeting. And I was able to hear and pick your brain a little bit. So it's actually nice now to do a podcast with you. So Dr. Hong, please share with our audience how you decided to become a radiation oncologist and your pathway from master's research and PhD, because it's been a very unique journey. So we'd like to hear that.
Well, Scott, I was very fortunate to do a radiation oncology rotation as an intern at a hospital in Sydney. And that really opened my eyes to the world of radiation oncology. I love the interaction with patient and the carer, how we could use a very powerful machine and to give a very precise targeted treatment. I love the range of disease in radiation oncology, so the specialty is not really confined to one single organ. You see a range of age group, pediatric to elderly patient. Basically, you get cancer anyway, so you really look after a wide range of patients. In terms of my research, my higher degrees, I was encouraged by my mentor at a very early stage to do research, even before I got into radiation oncology training in Sydney. And an opportunity came up for us to travel and work overseas, and I ended up doing laboratory research and started my love in research.
Well, it definitely took you along the way, and it sounded like it was just a per chance rotation. You got excited about that, and you did comment that you had a mentor that kind of recommended the importance of research. But you did some basic science research, which is quite unique. And how did that tie in with radiation oncology and the lab work? Because then you went on to get a master's and a PhD that was a little bit even different than that.
Yeah, so I finished my internship here in Sydney, and then we were traveling. At that time, my husband and I, he was doing a fellowship in US in ophthalmology. I knew at that time I wanted to get into radiation oncology training, but I was very junior at that time. I only done my internship, so there wasn't really an opportunity for me to start doing clinical radiation oncology in the States. So I wrote to the place we were traveling to in New York and said that I'm available, I'd like to learn more. Is there a chance for me to work in your department? And that's how I ended up in the lab. Yeah.
Oh, wow. Quite interesting. Was there always a plan to go back to Australia and to develop the clinical program in radiation oncology, or is that just something that just came after your training?
Well, we were doing a 2-year fellowship in the States, so the plan was always to come back to Sydney to start my training.
Got it. You know, when you and I visited, I learned a lot about the clinical trial infrastructure within the Australia, and I know here in the United States we have the National Cancer Institute cooperative group mechanism. We have SARC, and we also have other cooperative relationships. Maybe you can share with our group, how is the Australian group organized, because that's a different, uh, obviously a different country, but they also have a different system set up for cancer delivery and clinical trials.
Yeah, so in Australia, we also have cooperative trial groups. So specifically for sarcoma, we have the Australia and New Zealand Sarcoma Association. The infrastructure is funded by a competitive grant from the Australian government. And the majority of the board members are medical, but we do have consumer, scientists, and a very experienced corporate executive on our board. Within the association, we have a scientific advisory committee, and I'm the chair of that. And we also have a very active consumer advisory panel. For all the research we do within the trial group, we rely on competitive funding and also philanthropy to conduct research. So there are about 10 different trial groups in Australia. One for Australia, sarcoma, then we have the breast and GI and brain cancer, um, and all funded by government.
So it sounds like the organizational structure and design is very similar to that of the United States. I wanted to highlight a little bit. You did say you have a patient advocacy component, because we do also at SARC have that in each of the cooperative groups. Can you share with our group, because there are a lot of people from advocacy groups do listen to the uh, podcast as well. How does that work in Australia?
So the consumer advisory panel is about 5 of them. They are all consumer or carer who has some connection to sarcoma diagnosis. So they meet regularly, provide advice to the board in terms of the research they like to do, what sort of patient information they like us to prepare, and education. The chair of the advisory panel is also a board member, and that's how we get feedback from the consumer. They also help us with study design. So as soon as someone have a concept, we get input from them. Is that an important clinical question? Is there something else we should be looking at? What endpoints they think is important? They help us with education and also help us with fundraising.
Fundraising is a big aspect for all of us, so I do, it's helpful. And I think what I'm hearing from you all is that you use the word consumerism. Is that correct?
Correct. Yep.
Yep. And we use the word patient advocacy, so I think it's in the same mindset. But they really help inform the design, what gets studied, and also help support the study financially, if can be, and recruitment, it sounds like, as well.
That's right. Yeah.
In each of the groups, you said there were 10 different groups there. There's an active sarcoma group there as well. And I assume you said you are part of that group, or maybe lead that group as well. And maybe how does that all work? Because you have 10 different groups, and how do you stretch yourself to 10 different groups?
So there's one specific one for sarcoma. So the Australian New Zealand Sarcoma Association. The other breast cancer, prostate, GI, brain, pediatric. So we work in parallel. The only other group we have interaction with is the pediatric oncology group because of the crossover sarcoma. So we collaborate a lot. For example, the FARM study, which is a retinal sarcoma study, across both pediatric and adult, and the Ewing sarcoma trial, also across pediatric sarcoma trial. So we work together in terms of opening study in adult hospital and also pediatric hospital, in terms of ethics application and getting funding. So we work very closely together with the pediatric group. Yeah.
So that's where the contacts are. It's probably with the pediatric group and the sarcoma team. And your sarcoma team is a multidisciplinary team, and we're quite fortunate to have your, I would say, sarcoma team part of the Stand Up to Cancer SARC 32 study. And how did you get involved with that, us at SARC for that study?
So the international PI of SARC-032, Dr. David Kirsch, was actually invited to our scientific advisory meeting of the Australian New Zealand Sarcoma Association back in year 2015. So at that time, he was designing the study. He spoke about the laboratory finding that formed the design of the trial. And to me, that was very attractive. By that time, I already had some experience of using radiotherapy and immunotherapy in patients with melanoma. So I saw the synergy of radiotherapy and immunotherapy and thought that that was really exciting and very promising trial. So that was in year 2015. So after that, we spent the next 2-3 years trying to work out the logistic of how to get the trial open in Australia. It wasn't easy. I think that was the first time that SARC had tried to have a study in Australia. So the CEOs of SARC and Australian New Zealand Sarcoma Association had many morning talks just like this and try to get the logistics, get the contract, get the governance, how we're going to ship the sample from Australia all the way to the US. And we finally had it open in September year 2018.
Well, it's interesting how Dr. Kirsch, and we interviewed him too at SARC Talk, and heard a lot about the design and the importance of radiation oncology studies at SARC. And it was just by chance that he was an invited speaker over there, and from there, a great relationship has been developed. As you highlighted, SARC 32 was designed pre-COVID. A lot of the accrual happened during COVID time, and that posed a lot of unique challenges for all of us across the world, especially in cancer-related clinical trials. However, your group was able to continue to accrue a lot of patients, not only during COVID, pre-COVID, but after COVID as well. And maybe can you share with our group how that was able to occur? Because, as you know, you're one of the top accruers of all the SARC 32 studies, and we want to share the good news of how that happened and what was the secret sauce, as we would say, that allowed that to happen.
I think the secret sauce is a very strong multidisciplinary team at our site. We have a group of surgeons, medical oncologists, and radiation oncologists, pathologists. We work very, very closely together. I mean, whole COVID hit us hard. We had multiple lockdowns. We work from home, and some of the other trials actually closed at that time. But we didn't close SARC-032 at all, as our site was the main adult sarcoma center in the state, and patients were still referring to us for management, to have the surgery, to have the radiotherapy. And also by early 2020, when we had the COVID, we already had a few patients on the trial and on the experimental arm, had pembrolizumab with radiotherapy, and we saw very impressive pathological response. And we knew we were onto something. And basically, we didn't want patients to miss out the opportunity to join the trial and potentially accessing immunotherapy because of COVID. They were having the surgery, they were having the daily radiotherapy. So it wasn't too challenging to randomize them and add in a few cycles of pembrolizumab while they're having radiotherapy. So we kept the trial open throughout COVID. Obviously, we took precaution as recommended by the health authority at that time. We had telehealth. we accepted electronic consent form. For a couple of patients, we actually gave hypofractionated radiotherapy. So instead of the 5 weeks of radiotherapy, we changed to 3 weeks after discussion with David Kirsch to minimize the number of visits. So we were nimble, but the main thing is we decided this is a very important study. We didn't want to close recruitment. Yeah.
Well, we're very excited and grateful that you didn't close the study down, that you actually continue to accrue quite readily. And you bring up the point of the importance of a multidisciplinary group. And that's part of the theme we do have here at SARC as well, is that in order to provide care for patients with sarcoma, you need to have that multidisciplinary group. And that's not just the main, or not the players of surgery, radiation oncology, medical oncology, pathology, rehabilitation, social worker, dietitians, the whole components of a multidisciplinary team. And I know it requires everybody to be actively engaged. Um, is that the sentiment in other disease-oriented cooperative groups? Because in sarcoma, we think we're special. So we have a real good relationship with everybody that we just discussed. I assume that you're involved also with melanoma as well. I assume that same relationship and the importance of multidisciplinary does occur, but we like to think we're special in sarcoma. So maybe you can share with the group here is, how important is your work with the surgeons, the medical oncologists, pathologists? How does that work in Australia?
Well, it's very important. We think we are special in sarcoma. I think it's really quite unique. We really rely on everyone's input to come up with the best management. I mean, for example, during the SARC-032 trial, there were biopsy. Pre-biopsy, we need to prepare to send off the trial, on treatment biopsy, and then during the surgery, actually collection of the fresh tissue. And for the translational component of the trial. So a lot of coordination. Basically, I try to make life easy for everyone, especially the surgeon when they're busy operating. We prepare everything, remind them, hey, don't put the specimen in formalin. We're there to collect.
Yeah.
I mean, this sounds very basic, but it's very important when they're busy operating. They're just so used to put things in formalin. We're there, we remind them, we try not to be too intrusive, but we're hanging around outside the operating room there to collect the specimen. That kind of details. But in terms of sarcoma, so diverse. We talk about soft tissue sarcoma for the SARC-032 trial, but don't forget there's osteosarcoma, Ewing sarcoma, where preoperative immunotherapy has a very strong role. So it's the timing, make sure the patient are getting a scan at the right time in terms of after induction chemotherapy, the right time to have the local treatment. So it's a lot of talking. We have a very good coordinator for our clinic in terms of making sure every patient is getting along the journey, seeing the right people at the right time, getting all the scan done. So it's a very important component.
You probably undersell it, but we at SARC rely heavily on actively engaged principal investigators like yourself to remind the surgeons, don't put that in formalin, because as Dr. Kirsch and you guys know, SARC-32 has a heavy, heavy component of correlative studies that's going to be really important as we figure out why it worked, and more importantly is how do we build on that in the future. So in case no one's told you, I know they have, thank you so much for being an active PI to making sure that that happens, and did happen and continues to happen. You are also involved with melanoma research as well. I think Australia has a lot of melanoma because maybe the atmosphere over there. And, you know, we think, as we kind of said, that multidisciplinary is important. Many of us over time have really only focused years and years on multidisciplinary sarcoma. Some of us have also had experience working with other disease groups as well, and maybe you can share what it's like to work outside of sarcoma so other people can hear a little bit of how that works and kind of the similarities and the dissimilarities between both, or just pick any of the two disease groups that you are active in.
It's a very interesting question. There are probably more similarities than difference between melanoma and sarcoma investigators. So 15 years ago, both the melanoma and sarcoma MDT meeting focused probably heavily surgical. Nowadays, the melanoma MDT team is all talk about adjuvant, neoadjuvant systemic therapies at one drug, two drugs, three drugs, and moving the neoadjuvant treatment to early stage disease. Also, a lot of work on prevention, which is not such a heavy features in sarcoma world. I can see and I hope to see that sarcoma is heading that way, finding a systemic cure for patients with metastatic sarcoma. Surgery and radiotherapy, we can control the local disease. Usually it's very well, but it's the metastatic disease that we still don't have a good answer. It will be very complex because of the many histological subtypes of sarcoma. But hopefully one day that we will be sitting there talking about different drug combination. Do we do it in neoadjuvant setting? Can we do it in very early stage sarcoma to achieve a cure?
You bring up the point, and I think many of us that have been around do remember the day when melanoma and sarcoma were together.
Yeah. Mhm.
And then after gastrointestinal stromal tumor, just that split off. And then with the advent of immunotherapy, uh, BRAF treatments that were very geared, totally different, it went away. But it's really the same philosophy. So it's interesting.
It is, yeah. And the surgeons often the same group of surgeons doing both. Yeah. Separating now, as you said. Yeah.
I was quite impressed with the work that you've done with guidelines. And we love guidelines. And I know that you've been involved with the guidelines there. And maybe you can share with our audience here kind of how the guideline group works in Australia. And then the other part too is how does that compare with ESMO guideline, ASCO guidelines? And we at SARC have not really put out many guidelines per se, but just like to hear your thoughts of how it worked and kind of the opportunities.
So I chair the Australian National Guidelines for Sarcoma. So various, we have three board topics. One is on management as specialized center. Within that, we have three clinical actions, like does having surgery in specialized center actually improve outcome, radiotherapy, and the importance of second opinion in bone and soft tissue tumor pathology. And the second topic is on retroperitoneal sarcoma, the roles of preoperative therapy, chemotherapy, multivisceral resection for sarcoma, and then the third one is pediatric AYA. Some of the topics are quite challenging to do. So with each question, we do a systematic review using a PICO model. And because of often lack of high level evidence or randomized data, or sometimes you only have one randomized data trial of a few hundred patients, so it's quite difficult to actually put the information together and synthesize them and come up with a recommendation. But we are very specific for a clinical question. So it's not just broadly where should patient have radiotherapy or when's radiotherapy indicated. So it's very specific what is the roles of preoperative radiotherapy in retroperitoneal sarcoma. What is the roles of visceral resection in retroperitoneal sarcoma? So specific clinical questions. So we come up with recommendation. Hopefully that will help to guide management and ultimately improve the patient outcomes. But some of the questions, as I said, it's not easy to do. For example, the topic or the clinical questions on preoperative radiotherapy in retroperitoneal sarcoma. There's only one randomized trial of 260 patients, lots of retrospective data, and there's still different interpretation of the randomized data. So we try to summarize the data and come up with recommendation. The guidelines are there to help to improve the outcome of patient, try to optimize management. With our guidelines, we also have a plain English summary of each questions, and that's also translated to 7 languages. And this is try to empower the patient with information and help them to make treatment decision.
Got it. So in the US, we rely a lot on NCCN guidelines. And, many of our sarcoma colleagues are involved with that. They tend to be very broad and very generalized. And I know that yours are much more, as you said, clinically focused with a clinical thing. That makes huge sense. We've talked to other international groups on guidelines, and a lot of the guidelines are trying to address reimbursement for certain procedures, certain drugs. How much do those questions help inform you working on those guidelines, or are they just a side product of your guidelines that it does happen to be an indication?
So we are not focusing on reimbursement or what is available on what we call our PBS, which is the funding from government to use certain drugs, PBS mainly. We are focusing on evidence base. What is the best for a specific situation in patient with sarcoma?
That cleans it up a lot. So it's just the, the care of the patient, and then let other people figure out whether it's reimbursed, et cetera. Is that what you are saying?
That's right. And we also try to look at the evidence. How does it apply in Australia? Um, I mean, most study into of the data from other countries is still very applicable in Australia, but we try to look at it from an Australia healthcare system point of view.
Yeah, interesting. So you've been involved with this SARC study, SARC 32. Where do you see your multidisciplinary group, your sarcoma team in Australia, next steps working with SARC in the future? What are your thoughts?
Well, I hope it's going to be an ongoing relationship. SARC 032 is a success. It's the first step, first study showing a benefit in adding in pembrolizumab in soft tissue, high-risk soft tissue sarcoma. But there's still lots of unanswered questions. We in that study there was neoadjuvant and adjuvant pembrolizumab. Obvious question is, do we need the adjuvant pembrolizumab? Can we just do 3 cycle? What about combination immunotherapy with radiotherapy? Would that be better than a single agent anti-PD-1? There's still unanswered questions, and I guess the question is, do we need radiotherapy at all if we have effective immunotherapy?
Oh,
And the
you sound like a
radiotherapy,
melanoma doctor all of a sudden. There you go. Yeah.
yeah. And the radiotherapy we used in a trial was 5 weeks of treatment. I think we are heading in hypofractionated treatment, 5 weeks, reducing 3 weeks. Is it possible? So there's still lots of unanswered questions. So we hope that there will be the next trial. I'm sure David is thinking about that and try to improve the outcome. Yeah.
We won't tip our hats here, but David is working on it, as you do know, and all those suggestions have been thought through in that group there. So like you said, many years ago, it was standard 5 weeks. There are studies, as you know, maybe hypofractionated 3 weeks that helps patients care. Well, what's the components of immunotherapy in this whole regimen? So I do think there's more questions, and that's why I think having outstanding collaborators, because um, it's important to get these studies answered quickly and appropriately, and even if it's positive or negative, it's important to know that and move on. We don't want studies languishing for years and years because, as you know, newer drugs and newer ideas are going to keep coming up. So it's an exciting field to be in. As you were mentored early on in your career, you probably have the opportunity to mentor younger individuals that are coming through. What advice would you give junior staff that might be listening? And, or more importantly, is what advice do you give to your junior staff that are interested in a career in sarcoma?
So I would say broadly, don't do it alone. Talk to the multidisciplinary team for the input right from the beginning of the design of your project when you have an idea. Talk to the rest of the team because they're going to have a unique point of view that's going to help you with your project, help with your design. I keep saying that the importance of multidisciplinary team. Truly, you can't do any research on your own. If you just confine yourself in your own specialty, radiation oncology, is going to miss something that is very important from the surgeon point of view or the radiologist point of view. So that's very important. And I guess more on the practical level, day-to-day doing of the research, I would say collect good, clean data. Just remember garbage in, garbage out. That's very important. You don't want to come to at the end of your analysis find out that you actually missed something very important right from the beginning. Yeah.
Yeah. But you bring up the point there, garbage in, garbage out. You and David and the team spent years making sure the study was designed, making sure the correlative studies for SARC-32 were appropriate. And that's going to be a gold mine, as you said, but you guys were very intentional.
Yes, yeah, we have a radiotherapy QA component, make sure the radiotherapy was done appropriately. The regular QA from SARC in terms of our data entry, data chase, make sure everything is done on time.
Yeah. Well, no, that's very interesting, and I think that's why I'm going to take away is you can't do it alone. Be it in a multidisciplinary fashion. You know, it's okay to talk to other radiation oncologists, but you also need to talk to the surgeons, the pathologists, the medical oncologists, the radiologists. So I think that's a great point, and I think sarcoma lends that extremely well because, and if we're going to move forward, that's what we're going to need. Well, Dr. Hung, thank you for sharing about yourself, your journey, and how sarcoma is run in Australia, the importance of guidelines, and I'll reiterate the importance of a multidisciplinary approach. And we do look forward to further collaboration with the Australian sarcoma group, as we would say. Do you have any final comments to our audience or to us here?
Well, thank you for shining the spotlight in Australia and in radiation oncology, and we also look forward to ongoing collaboration with SARC.
No, thank you. Thank you all for listening, and we'll be back for another episode of SARC Talk where we interview interesting people like Dr. Hung who are connected to sarcoma, where we can all share and spread the knowledge of sarcoma. So again, Dr. Hung, thank you so much for being here with us today, and we thank you for getting up early and being here Australia time, and we look forward to continued collaboration. So thank you.
Thank you for listening. Be sure to subscribe so you never miss an episode of SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. The SARC Talk series is made possible due to funding from Boehringer Ingelheim. Together, we can find a cure for all forms of sarcoma.